Okay. What makes that what it is? Anybody? Nobody?
The P waves and the QRSs are on their own rate.
Okay, my P waves and my Q waves are at their own rate. Somewhat, kinda, but somebody give me a different explanation.
Nick says wide QRS.
Okay, QRS is wide. I would agree with that. But what else? Because it doesn't always have to be wide in this.
You have extra P's.
Okay, your extra P waves. I'd agree with that. Now, I have extra P waves. Is this a regular or an irregular rhythm?
Irregular.
Irregular. Okay. Now, look at my PR interval when I do have complexes there. What is it doing? Where I have QRS complexes, where the P waves are right in front of it, how short is that complex? Okay, it's normal.
Very short.
It's normal, right? So my PR intervals are normal where I have complexes. I'm just dropping complexes every now and then. Second degree type 2, more P waves than Q waves. It is just a block that comes and goes. As compared to this block, it looks very similar. Like if I took that middle complex out, I would have a second degree type 2. But since I don't have that, since I have uniformity, do I have a regular rhythm or is it irregular?
It's regular.
It is regular. Absolutely, it's regular. Now, is the distance from one QRS to the next QRS the same?
Yes.
Okay, so that tells me it's regular. What about the distance from one P wave to the next P wave? Are they about the same?
Yes.
Yeah. That's what makes a third degree block what it is a total disconnection from the top to the bottom of the heart. The top of the heart is your P waves. The bottom of the heart is your QRS complex. That QRS complex is wide because it comes from the bottom of the heart. The lower, the slower. Lower in the heart it is, the slower it's going to be. If this was a 6-second strip, what would my heart rate be?
30.
30, right? Okay. So let me pull something up real quick. I think this is it. We're going to go through some of these practice strips. They don't tell you what they are, and you have to try to figure it out. Okay. So, gives you a scenario with it. Your patient is a 60-year-old male, unconscious, BP is 70/30, heart rate is 160, respirations at 30. Sarah, walk me through this. What's my main concern here with this patient?
The heart isn't able to relax, refill. It's going right back into it.
Okay. There's no space to allow the heart to refill, to relax. I'd agree with that. So if you had to look at that rhythm, Sarah, what would you call that rhythm? And why?
I'm not sure. It's regular.
Okay, let's talk through it. It's regular. Do you see a P wave?
Barely. I mean, it's
Okay, let me do this.
hard to tell what's a T and what's a P on
Huh. Okay, so you just told yourself what the rhythm is. If I can't tell what that is,
that. Mm-hmm.
and my rate is 160, if I put it that way, what would you call this rhythm?
AFib?
Nope. Remember, AFib is irregular, right?
SVT.
Oh yeah, SVT.
Okay. SVT. So tell me why it's SVT, not Tanya, Sarah. What are the characteristics of it? I'm fast. I'm above 100, so I'm tacky, right? Do you agree with that? Anything
Correct. Yes.
above 100, I can consider tacky. It's regular. And I can't tell
Oh, where the P wave is.
between a T wave and a P wave. Automatically, I call it SVT. Okay.
And it's over 150.
Yep. So let's talk through the treatment of this rhythm, okay? And there's nothing wrong if you don't know the answer to it, because that tells me, hey, let's talk about it. Let's go through it. Let's talk about the treatment of this. Now, I'll pick on somebody else here. Now, Tanya, it's Burgess, it's your turn. Okay, Tanya, would you say that this patient is stable or unstable?
At this point, he's stable
Well, why would you say they're stable?
because his respiration rates, but well, I'm sorry, I didn't see the blood pressure. No, he's unstable. So we could either can cardiovert first or try meds.
Okay. So when determining stability, there's two things I look at.
Unconscious and blood pressure.
If one of those is skewed, my patient is unstable.
So he's unstable, yes.
Okay, he is unstable. Now, I have two pathways. I have the stable pathway and I have the unstable pathway. What did you say my unstable pathway was?
Unstable would be cardiovert. Stable would be meds first, then cardiovert.
Okay. Cardioversion, I would agree. Unstable patients get electricity. Stable patients get meds. What med do I give this person?
Adenosine.
Adenosine.
Okay. What is my first dose of adenosine?
It is
6 milligrams.
0.6.
6
What's my second dose?
12.
12.
Okay, 12 milligrams. How fast do I push adenosine?
As fast as you can.
As fast as absolutely possible. Who was that just put that in the chat? Was that Nick, I think? He put in there medicine before Edison. Does that kind of make sense? In stable patients, we give medicine before we give electricity. Thomas Edison invented the light bulb. But we have to determine if they're stable or not, because this could be a national registry question right here. Patient's a 60-year-old male, unconscious, but BP 70/30, pulse at 160, respiration's 30. And I see that rhythm. Yeah, he's unstable. I'm going to consider cardioverting this patient. Okay, let me pick on somebody else. I noticed I don't pick on enough people in this class, so let me look at my phone and see who's all in here. Anna, how about you? Are you then? Are you here?
I am here.
Okay, let's talk through this. 64-year-old male, chief complaint of chest pain, BP 190 over 100, pulse rate is 40, respirations at 26, pale and sweaty. Moved up.
Yeah, I was about to say, you're thinking the same thought I am. I know tachycardia and bradycardia pretty well, but this one's got me confused.
Okay, why has it got you confused?
Because of the dip.
Okay, so let's look at this. This QRS complex looks way different than this one, don't it?
Right, yeah.
Okay,
So
does
there's something
anybody?
going wrong
Well,
after
does
the
anybody?
AV node? Sorry.
Well, does anybody remember what I said? If you have a ventricular beat that fires early, what it's called?
A PVC.
Okay. So this could be in my opinion, sinus rhythm with PVCs. Every other beat is a PVC. Okay. Now, Anna, you said you're really good with your tachycardias and bradycardias.
Yeah, those are
Okay. This guy's heart rate is 40.
right. So he's bradycardic.
Okay. Stable or unstable?
Pale, sweaty, one unstable because his blood pressure is way too high.
Okay. How are we treating him?
Because he's unstable, we would pace. No, not pace, cardiovert. Otherwise, I'd give atropine.
You had it right the first time.
Right.
We pace for slow rhythms, but cardiovert fast. Or you could give him atropine if it was if you considered that. Absolutely. Does anybody see a heart block here?
First degree.
Okay, let's see. Where do you see a first degree at? Tell me why.
P waves are extended out from the QRS.
How far are they extended out? How many boxes?
About 2, maybe 3.
Okay, but actually remember it starts where the P wave starts. So I've got 1, 2, 3, 4, 5. I've got 5 small boxes. What does that equal in time? 5 small boxes equals what?
0.2.
Yeah. What's a normal PR interval?
Yeah, that's normal. Never mind.
There you go. All right. And that, to me, honestly, and I probably wouldn't call it sinus rhythm. Maybe I would call this sinus Brady with PVCs. It doesn't change my treatment. My patient has a slow heart rate. My patient is unstable. What do I always tell everybody about treating patients?
Treat the
Treat the
patient, not the monitor.
Treat the patient, not the monitor. If you sat here and stared at this monitor forever, you'd be like, I have no idea what I'm going to do for this person. But if I gave you this same scenario and said, hey, my patient's got a heart rate of 40, then they're unstable, treat them. You'd be like, okay, I'm going to pace them. Don't get so caught up on the rhythm that you forget your basics on treating certain cardiac conditions. That makes sense. Do you need to know them? Absolutely, but you need to know how to treat them more than anything. We're gonna skip past that one. Okay. Cassie, how do you feel about rhythms?
If I have my guide, I do okay.
Okay. Talk me through this one. First, let's identify the rhythm.
Okay.
And don't anybody blurt it out.
Well, can I cheat and use my guide?
If you want. I have protocols in the back of my ambulance.
I mean, it looks like the polymorphic ventricular tachycardia.
You're really close. But not there yet.
Hmm.
It's a part of VTAC, but not polymorphic. Polymorphic would almost look like,
So they're not all the same height.
yeah, polymorphic is more torsades.
Okay.
That looks like a sound wave going up and down. Monomorphic, mono meaning one, they all take one shape.
Okay, so monomorphic
Yep.
VTAC.
Yep. Okay. Let's talk through our patient now. 50-year-old male, awake, alert. BP is 110/170. Pulse is 190. Respiration is 20. Skin warm and dry. Is my patient stable or unstable?
I would say stable.
I would 100% agree. That's a stable patient. Okay. What is the first thing that we can do to try to slow his heart down?
Like without medication,
Yeah, without medication.
just ask him to take slow, deep breaths, sit down still. Like if he's up moving around, he could have been having a panic attack. So sometimes just sitting down, taking breaths is helpful.
Okay, what else?
You can put him on oxygen if he needs that to assist.
Okay, what else? Something maneuver.
I don't know.
All right, who's got it?
Vagal maneuver.
Legal.
Ah,
There we go. Try to get him to vagal down first, right? Because he's stable. Don't worry, you'll get it. You'll get it with time. Second line of treatment. Vagal maneuvers fail. Now what?
so we'd have to give meds, but
Okay.
I'm not sure what med.
Okay. And this one will trip people up a little bit. Does anybody know what my first med that I have to consider is?
Amiodarone.
Okay. My first med per, and you guys haven't been through ACLS yet, but my first med per protocol says I consider adenosine first. Consider is the key word. Okay, I looked at adenosine. I don't think it's perfect for this patient, so I'm going to bypass adenosine and I'm going to go to amiodarone. What's my dose of amiodarone for a stable patient?
300.
150 over.
10 minutes.
300.
150 over 10 minutes.
150 milligrams over 10 minutes. In hope that this patient converts. Honestly, here's another thing to consider too. And you are not wrong to do this. First patient I ever had stable VTAC, I didn't do a damn thing for him. I drove him to the hospital. I called medical control and said, hey, here's what I got. Do you want me to administer excuse me, do you want me to administer an antiarrhythmic such as amiodarone to slow his heart down? And they said, no. If he is stable, get him here. We will take care of it. We have these options in our protocol to do it. Did I have to call him? No. But in my mind, I thought, God, if something goes south, it's going to be on me. Let me call a doctor and just see what they think. There's nothing wrong with that. Now, how would this have changed if his pulse was 0?
CPR.
Okay, first thing we do is start CPR. Okay,
That'd be late.
And defib.
and defib. Absolutely, we would shock him as soon as we can shock him. Question: how many shocks in this rhythm do we have to give before I can start giving meds?
2.
2 shocks. Okay, so we do CPR for 2 minutes. We deliver another shock. What's my first drug?
Epi.
Okay. We're doing CPR again during that time for 2 minutes. We come to a rhythm check. I shock. What's my next drug?
Ambulance
Amiodarone.
100.
What's my next dose of amiodarone after that?
150.
That's literally what ACLS protocol is. ACLS is nothing but 16 hours of going through cardiac arrest rhythms. That's it. Again, I feel bad. Let me pull your names up because I want to call on people that I really didn't call on last time. Matt Dickinson.
Yes.
23-year-old female. Blood pressure is 110/70. Heart rate's 160. Respiratory rate 20. Your patient is awake, alert, and talking to you. This is a 6-second strip. What is my rate? What? Not my rate. What is my treatment of this patient, and what is that rhythm?
So first off, it's got a fast rate, so we can start by vagal maneuver since she's a learn oriented. I can see that the QRS complex is not wide, so it's narrow. So since it's narrow, I'm trying to remember because it's either trying to remember because is SVT wide or narrow for the QRS?
Narrow. QRS will always be narrow in SVT.
Okay, so this is going to be SVT then.
Okay, why isn't it sinus tach?
Because the P's and T waves are combined, so you can't quite make them out.
P waves and T waves are combined, so I can't quite make them out. Okay, first treatment's vagal maneuver. Second treatment, she's stable.
So since she's stable, we can do something for fast heart rate. So I'm going to do adenosine.
Okay. First dose.
First dose is 6.
Second.
12.
Okay. Good job. There's something I want you guys to do for homework to review, and I want you to look at what a Valsalva maneuver is. VALSAVA maneuver. You might be able to get to see them do it in the cath lab. You might be able to see them do it in the cath lab recovery. Usually cath lab recovery and the cath lab, you'll get to see patients cardioverted, you'll get to see patients paced, you get to see some cool crap in those units. So please take full advantage of it. Oh boy. Alex Fulton.
Yeah.
Tell me my rhythm. Don't sound scared. Tell me your rhythm.
I want to go with VFib.
Go with what? Speak up.
VFib.
VFib. Okay. Why? Why is it VFib?
Heart's kind of just tremoring. You're not really getting anything for a rhythm.
Okay. Tremoring, not really getting a rhythm. Okay. Can my patient have a pulse in VFib?
No.
Don't ever question your patient will not have a pulse in VFib. They are not getting a squeeze of the heart. Okay. How do I treat it?
CPR.
Okay. Then what? What do I want to do as quickly as I can?
Check.
Shock the patient, and then rounds of epi.
Whoa, 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 whoa. How many shocks do I give for epi?
2.
Okay. Epi. What concentration of epi?
1 to 10,000.
Okay. I'm gonna keep putting you through the ringer here. I'm still doing CPR during that epi for 2 minutes. Rhythm check comes up, same thing. We're gonna do another shock. My next drug is what again?
Amiodarone.
Okay. I want to give 300 milligrams. How many vials do I need?
2.
How many is in each vial?
150.
Somebody's been looking at drugs. Good job. Shane. What rhythm?
A flutter.
Okay. What if I said this? What rhythm?
I'm not sure.
Okay. Who thinks they got it?
AFib.
Nope.
PEA.
A.
Pulseless electrical activity. It will look like the patient has an organized rhythm, but they do not. If this patient had a pulse, Shane, what would this rhythm be?
Just be a regular. I know it kind of looks like little flutters in there, but
But not for all of them, though, right?
all of them no.
So you said the keyword there, irregular.
Yeah, it's just a regular rhythm.
Irregular rhythm. What do we call irregular rhythms?
I'm blanking. I'm sorry. Or yeah, AFib.
There you go, AFib. All right, so let's go back to PEA for a second. How do I treat PEA?
CPR.
Okay. CPR is initiated. Now what?
Get the patches on.
Okay.
Um,
Now what?
do your 2 rounds shock if indicated.
Okay. But can you shock PEA?
No.
So I agree with putting patches on. I put patches on all my patients. I don't care if they assist PEA, because if they go into a different rhythm, I can shock them. CPR, then we do epi.
Yep, epi.
As soon as possible.
Yep.
Then 2 minutes of CPR, rhythm check, CPR, epi. We just alternate CPR and epi. We're not giving amiodarone because there's nothing to convert, and we're not shocking because there's nothing to shock. It is the exact same treatment as a systole. Exact same. We treat it the exact same way. If the patient goes into VFib or VTAC, then we have a rhythm we can work with. But PEA, non-shockable, we don't do anything besides CPR and epi.
How long do you usually wait? I mean, how many cycles do you do before you call it?
It depends on your protocol. Usually, most places will say 20 minutes. Because you're giving, generally epi is every 3 to 5 minutes. Most places carry 5 rounds of epi. 20 minutes roughly.
Thank you.
Rudy, I got a question for you.
Yeah.
What's the, and maybe you don't know the answer, but what's the thought process behind only giving 2 rounds of epi during codes?
Only giving 2 rounds of epi during codes?
Yeah, so like the ambulance service in Cedar Rapids changed their protocols, and they're only allowed to give 2 epis during codes.
Is that area ambulance?
Yeah,
I have no idea.
because I haven't
When I
heard
did
of
ride,
anybody else
they
doing
told me
it.
it's because of shortage.
I could see that, but I can tell you what most services did during the shortage at all as 2. And what my service did was we just took a flush with epi 1-to-1 and mixed it up. Because if I take 9 mLs of saline plus 1 ml of 1-to-1, what did I just make? I just
Epi
made
10,000.
Yeah, I made 1 milligram of epi and 10 mLs, which is what those vials are. Yeah, I'm not sure why they would do that. The only thing I could think of is for a shortage, to be honest. I don't know. And honestly, I might email them just to get their protocol on that, just to understand why, and not because I'm nosy, just because it'd be good to know.
Yeah, I just thought it was interesting.
Now, the only thing I can think of is I know that there's been talks about, are we overdosing our patients on epi? The problem is we are not practitioners. We can't go out there and say, hey, because I read this study, I'm going to do this now. We have to follow protocols. If their doctor signs off on that, great. But that's not a decision that we can make. But yeah, I'll have to ask them. I'm not sure. That's a good question. All right. Ethan.
I'm here.
Tell me what we're looking at.
35-year-old. He's sinus bradycardia. Oh, never mind. He's in a 2nd-degree block.
Okay, which one?
Would that be a type 2 Mobitz?
I would agree. Why do you say that?
Got more P's and Q's.
Yeah. And what's his PR interval when there's complexes there?
Short, normal.
Yeah, normal, right? We don't have longer drop. We don't have a long PR interval. We just have more P's than Q's. I'd say that's a 2nd-degree type 2. Okay. Here's an issue. Stable or unstable?
70 over pal, P's unstable.
Okay. What do you want to try to treat this patient with first? And there's nothing wrong with doing it. Because ACLS will say consider it.
Well, you could consider MedWise, atropine or epi.
Okay. How much atropine?
6.
How much?
Not 6.
1 milligram. You got adenosine confused with atropine. Okay, atropine doesn't work. Blood pressure's still crappy. He looks like crap. Now what?
Pace.
I would 100% agree. Now, stable route for this patient. How's it change? If this guy's blood pressure was 130 over 80 and he's just sitting there talking to you, no issues, and he has this on the rhythm.
Just leave him.
Yeah, how about we monitor the patient? Or we could, if need be, give atropine. Perfect. Oof. We actually already went through a VTAC. Does everybody see? Would everybody still consider that VTAC? Or does that freak some people out and they don't know what to look at?
Yeah, it's got me confused.
Okay, let's talk through it. Because you will have different rhythms that'll freak you out a little bit like this. Okay, so this is your QRS complex. This is your T wave. It's just an upside down complex. So if I drew it, it would look like that. Don't let that confuse you. You're still looking at this part right here. That is still your QRS complex in all of these.
What would you identify as a P wave?
If what?
What would you identify as the P wave?
There doesn't have to be a P wave in a ventricular rhythm.
So it's being consumed right there?
Or it just doesn't have one, because think just like VTAC. There's no P wave in VTAC. Or like you said, it's buried in there. But that hump after the QRS complex is always your P wave. Or is always your T wave. This is the same thing. Sorry, I drew that wrong. That's my QRS complex. That's my T wave. Either way I look at it, it's wide, right? I mean, from the base, well, technically I go all the way over here. So 1, 2, 3, 4, which gives me 0.16. It's wide. It's way wider than it should be. Still VTAC. Okay, looking at this pace rhythm. What type of pace rhythm is this? We have two different types. We have atrial paced and we have ventricular paced.
Is that ventricular based?
I couldn't hear what you said.
I said, is that ventricular paced?
Why is that?
Because it's a higher rate. It's kind of.
Nope.
No.
Why is this a ventricular pace rhythm looking at it?
Oh, because the pace phase spikes are coming from the ventricular area.
The spikes are right in front of right in front of the complex. Pace rhythms will always be wide. Okay. There's my P wave. The spike is after my P wave. ventricular pace rhythm. As opposed to this, I have a spike right here and I have a spike right here. What's that telling me?
It's pacing at the atrial and ventral sites, but it's pacing, it's biventricular, so it's pacing
Yes.
both parts.
It's pacing the atrium or the SA node, and it's pacing the ventricles. And this, how many of you have I shown this to you yet that we went through this paced rhythms where you couldn't get capture yet? Did it look very similar to this? And how do I, as a paramedic, what do I do to fix that?
Do you try overpacing?
Okay, I could try taking over pacing with my monitor. There's nothing wrong with that. You know, they don't teach anymore, and I think it's a shame. Does anybody carry a magnet in their ambulance, a big magnet?
That's right, the main will
Does anybody carry one of those?
Dallas County has them.
Dallas County has them. Okay. We used to use this giant magnet that would literally go over the patient's pacemaker, and it would reset it. You held it on there for about 5 seconds, and then you took the magnet off. It reset their pacemaker back to manufacturer standards, and then you'd watch to see if the pacemaker started working appropriately. If it didn't, you left that pacemaker over, or that magnet over their pacemaker, and shut it off. Well, if I shut off their pacemaker, I can just put my pads on and start pacing them. If their pacemaker fails, you still have fail safes on how you can treat this patient. Another instance, failing to capture. There's something I wanted to show you guys. Let's take a 5-6 minute break, and we'll come back and we'll look at some other anomalies. I'm trying to find something here real quick just to add to this PowerPoint, and then I'll pull it right back up for you guys. All right. So plan tonight, we're going to finish going through some other cardiac anomalies, maybe some stuff we haven't covered yet. Only like 20 slides. When I'm done with this, I'll let you guys go for the end of the night. Next week, we will finish up cardiac emergencies. And then what I will tell you guys, I had a student bring it in, God, was it today? It's an EKG Made Easy book. Nate, you have a copy of it as well. It's an orange cover. That is like the best book to get to help you with EKGs. You're not gonna remember and keep everything just by going through PowerPoints with me. That's not gonna work because you still have a whole nother half a year of paramedic school. Pick up some book and start looking at EKGs. Start looking at 12 leads. Get on Facebook. There's different 12 lead Facebook groups you can be a part of, and literally people post every day and talk about them. You have to be proactive about your education. Otherwise, I hate to say it, you could fall pretty quickly. All right, first 12 lead we are looking at. We're going to talk a little bit about them and what we're essentially seeing here. So, Shane, I'm going to give you a chance to redeem yourself on this one. Look at your 12 lead. Tell me what you see.
I have depression in 1, AVL. Got elevation in 2, 3, AVF.
Elevation in 2, 3, AVF. Okay, if you were treating this patient, what would you do?
I would call a STEMI alert.
Okay, call STEMI alert. I agree. What else could you do to help you maybe confirm a right side?
I could move V4 over and see
Okay,
if
move V4 over. I like that.
Mhm.
What if V4 is elevated?
And I've got a confirmed right side MI.
Okay, I would agree with that. Treatment wise, let's say this guy's blood pressure is 95 over 72. 10 out of 10 crushing chest pain. How are we treating this guy? What meds are we giving him?
To start off with 324 milligrams of baby aspirin.
Okay.
And then, see if we can get a line. If we can get a bag, then, depending on protocol, some places are 90 systolic, some are 100. Then I consider giving nitro. If you have a nitro drip, that would be a better option. That way you're not tanking them. And if that's not relieving pain, then fentanyl.
I like that. So what are you seeing in one in AVL? What's that called? When you have depression and you have elevation in your other leads?
Reciprocal changes.
Reciprocal changes. Boom. I like it. Good job. That is very similar. All right. Oh, Andrew Graham.
Yes.
I was gonna say, don't let me down, Andrew. All right. So funny story about Andrew, real quick, that we found out last week. I'm not gonna throw your business all out there, but I tested positive for COVID last, oh God, no, what, 2 Wednesdays ago, 2 weeks ago? So I was gone for a week. And Andrew, when did you test positive?
The day before you did.
Thank you. All right. What do you see?
Well, right off the bat, elevation 2-3 AVF. Depression in 1, V2, V3, and V4, and AVL.
Okay. What are you calling this?
Calling this an inferior MI, so I'd call it stimulant.
And remember, anybody that's not talking, if you have questions about it, please ask it during this. If somebody judges you, I will kick them out of this class. I swear to God. Inferior MI, call them stimulate. Okay, I like that. Treatment. What's your treatment where you work?
Treatment where I work.
Mm-hmm.
Well, the basics, because we're just a basic fire department, but
Okay. How do you basically treat it?
well, I wouldn't know any of this.
Andrew, damn it. You're
Well,
working
depending
for
on what
you're
they're
working for area ambulance. How you treating it?
well, depending on what, if they got chest pain, you could give nitro,
Okay.
depending on what their blood pressure is. But I would get a line started, probably give them a little bit of fluid, just. Okay, so if their blood pressure is that, I'd give them nitro.
Okay.
Give them 324 of aspirin. And then depending on what their pain is still, you give them morphine.
I like morphine is a great cardiac drug. I love morphine for hearts. Generally 1 to 2 milligrams of morphine will do the trick. Now, how many 12 leads are you going to do during transport? Or how walk me through how many 12 leads you're going to do and when you do them.
Well, you get one right away, obviously. And then I would get another one after I do all of this.
Okay.
After I give them all the meds, and then depending on how long the transport time is, I would probably get another one like right before you're getting to the hospital.
Okay. I like that. Anybody have any questions about that? Anybody have any questions how we saw elevation, depression, or any of that?
No.
I'm literally making it as easy as possible for you guys. It's not as hard as I make it sound. I promise. Okay. Scott Watson.
Yes, sir.
All right. I was hoping you were there this time.
Yep, I did not fall asleep.
All right. Walk me through what we're looking at.
Looks like we got narrow QRS, We're a little bradycardic. We have P waves. Major ST elevation in V1, V2, V3, V4. Depression in V6, AVF. So I'm gonna say like an anterior, maybe a septal STEMI.
I'm good with that. Anteroseptal STEMI. I'd probably agree with that. Are you as worried about nitro with a STEMI on this part of the heart as you are the right side?
No.
No, because the right side is what blood comes into from the body. So we get a little bit worried because if you give nitro, you cause vasodilation, blood pressure drops really quickly. That's a concern. On the left side, not so much of a concern, because if we have blood coming into the right, it'll flow into the left pretty easily to be pushed out to the body. Okay, good job. I'm not going to walk you through the treatment because does my treatment change medication wise versus what I see on this 12 lead?
No.
No. I still give aspirin. I still give nitroglycerin. I still give pain meds if they're having it. Treatment doesn't change. It ACS protocol. We follow it to a T, but we are able to look and see what's potentially going on so we can have early notification to our receiving hospital that maybe we're bypassing the ED. Maybe we're going straight to the cath lab. Why not? Okay, good job. Oh, here's a good one. All right, Cassie, I want you to tell me specifically, I have just one simple question. I'm not going to ask you to identify anything on this 12 lead. I want you to tell me what the axis deviation is of this 12 lead.
Oh, this is the thumb thing, isn't it?
Yes.
Oh, and I got it wrong last time we did it, so.
That's why we're doing it again. Okay, left thumb is what lead?
1.
Okay, left thumb is 1. So we'll put an L right there for 1. Right thumb is what?
AVF.
Okay, right thumb is AVF. You're 50% there. Okay. Put your thumbs exactly how those QRSs look. And tell me what you have.
Left is up, right is down.
Okay, so left is good, would you say?
Yes.
So I have left axis deviation.
Yes.
Anywhere you have the thumb up is where you have the axis deviation. Good job. Just walk yourself through it. You did great.
Thanks.
All right. Now, let me. Actually, Cassie, you can talk me through this 12 lead pretty easily.
Oh, great.
Tell me what you see.
Well, it's off in La La Land at the end of V4, 5, and 6. It's like going, so I don't know if that is just like a bump or something.
Okay.
We've got elevation in 1, 2, 3, 4.
1, 2, V1, V2, V3, V4. I would agree. So we've got elevation there. Okay. Do we have elevation anywhere else?
Maybe a little bit in 5.
Okay. What else?
No.
Maybe I'll tell you this, and it's a very big, maybe not. AVL maybe, but it's really hard to tell. But you're right on the other leads. So, what part of the heart, if you remember that picture I had everybody take, what part of the heart is that?
Inferior?
Nope.
Nope. Okay, I'm trying to find the picture.
No, you're good.
Anterior, septal, and lateral.
Anterior, septal, and lateral. I would agree. You've got lateral involvement because V5.
Yep.
So if I have anterior, septal, and lateral, somebody tell me what kind of heart attack that is potentially.
Is that the Widowmaker?
That is a Widowmaker. Whenever I have all three vessels on the left side potentially involved, I have a Widowmaker. This sometimes help people out too, and maybe if you need to take a picture of it, it'll help you. So remember, V1 and V2 can technically be classified as anterior. You don't have to call them septal. You can call them anterior if you want. I actually had a student teach me this last year, and I had no idea about it, on how to remember what leads go where. So V1, V2, V3, V4. Let me draw this out. I'm trying to think of a color that would really stand out here. Light green. That makes an A. Okay, everybody see the A? 2, 3, and AVF are inferior. That makes an I. 1 AVL, V5, V6 are lateral. That makes an L. It's just something that a student taught me, and it actually helped some people. If you need to draw me to draw in a different color, I'm color blind as heck after my doctor appointment apparently yesterday, so I can draw in a different color.
Yeah, can you do it in different colors so we can actually just tell the difference, please? Thank
Yeah,
you.
what color? Somebody tell me.
Do red or something.
Okay, let's do red. Okay, so 1 AVL, V5, V6 are lateral, so you make a big L. Okay, everybody see that L? V1, V2, V3, V4 are anterior. So you make a big A. 2, 3, and AVF are inferior. So you make a big I. Is everybody able to see that?
Yes, much better.
Okay. And again, that might help you a little bit because it correlates right back to the lead. So if you need to take a picture of that, by all means, go for it.
Hey, Rudy.
Yeah.
I had one of my paramedics teach me something to help remember where all the things are that I think might be super helpful.
Yeah.
It's called lie, lie, say all. So it's
Yeah. Mm-hmm.
lateral, inferior, inferior, lateral, inferior. And you basically just go down the line with it.
Yep.
So I found that super helpful.
Another one is ISAL. ISAL, inferior, septal, anterior, and lateral. Or some people will just say SAIL, SAIL. And that's how they remember the different parts of the heart. So whatever works for you, I don't care if it works. Just remember what leads look at what. All right, we'll do a couple more of these. Nate, are you still driving?
No, I'm good now.
Okay. I heard you driving and answering questions. That's why I said something. All right, walk me through this.
All right. It looks like we have elevation in V2, V3, V4, 5, and I can't tell. I don't know what's going on with V1 there, but That's where I can kind of see some elevation there.
Okay.
Looks like we have depression in maybe 3. So 2 AVF.
Okay. Axis deviation. Tell me what it is.
Both thumbs are gonna be up.
Okay.
So I can't remember what that one is.
Good access. Normal.
Good access. Okay, so that's normal then.
Yep.
It looks like the ischemia is gonna be on the right side of her heart or the inferior.
Okay.
And
Because
then
ischemia is depression, right?
yes.
Okay.
Then the injury or the is going to be on the left side and
Okay.
interior.
I'd agree with that. Good job. And we've done the inferior. We've done that. Does anybody need some clarification on bundle branch blocks?
I could use some.
Okay. So, to be a bundle branch block, the QRS complex has to be greater than 0.12. So greater than 3 small boxes. And we only look in lead V1. Don't look anywhere else besides V1. So let's say V1, that QRS complex is wide. What I then do is, again, the turn signal method is basically, hey, I drive her along. Which way do I have to turn here? I have to go left. So it's a left bundle branch block. Some people will also say, if it's negative, so if the complex goes down, it's a left. And if the complex goes up, it's a right. Like, think about if I was to turn this 12 lead. If I was to grab it in my hands and turn it to the right, so my left hand is now holding the top of the strip, my left hand's or where my right hand's holding the bottom. You see what I'm saying? I wonder if I can rotate this.
Counterclockwise is what you're saying.
Yeah. How do I get that up? Yeah, if I rotated this, no, rotate it clockwise. Sorry, not counterclockwise. If I rotated this clockwise, which way would my QRS be facing, left or right?
Left.
Yeah, that's all it is in determining a bundle branch. And literally, I don't care if you have to grab it and rotate the whole piece of paper clockwise and look at V1, see if it's wide. If it is, you've got some sort of a bundle branch block. You just have to figure out left or right. Majority of the complex is up, it's right. Majority of the complex is down, it's left. And when I say majority, because I can't have complexes that's still a right bundle branch block, but it looks like this. Well, a majority of it is still up because I have 2 parts that are up and only 1 part down. Does that make sense? And it'll make sense when I can actually show you in person. I know that sounds stupid, but like when I come up there for skills, it'll be a lot easier for me to show you guys in person. Okay. Looking at this bad boy. Who hasn't gone yet? Somebody, I don't care who it is. Or who wants to take a shot at it. All right, I'm gonna pick somebody at random. All right, Carrie, I hate to pick on you, but tell me what you see. Walk me through each lead.
Okay. So it looks like I've got elevation in 1,
Okay.
2,
You say 2.
yeah,
Okay.
elevation in V4,
Okay.
V5, V6, V2, and V3.
What about AVL?
Elevation in AVL.
Okay. All right. Who, and this is something new to you guys, who wants to take a crack at this and tell me what they think this is? Because judging off this, which vessels of the heart would be potentially involved?
Lateral anterior septal.
Lateral anterior septal, and what else?
Part of the inferior too.
Part of the inferior, right? Okay, so here's what doesn't make sense to me, and you guys tell me if it does to you. Why do I have elevation in 2, but not 3 or AVF? They look at almost the identical part of the heart. Doesn't make much sense to me. Yeah, I've got elevation 1, AVL, V5, V6, meaning lateral, but I've also got elevation in V2, V3, V4. I literally have elevation in every single coronary artery. So we call this widespread elevation. Now, what if I told you this patient was running a temperature of 102.1? And okay, so they're sick, right? And blood pressure is 99/70. And I don't expect you guys to know what this is. I'm just throwing this at you so you can remember.
Is this like a pericarditis?
What'd you say?
Pericarditis?
Why'd you say that?
Because of the temperature and the elevation in all the leads. So there's a fluid buildup and it's like not being able to pump as well as it's supposed to be.
You are absolutely right. Pericarditis. Okay, does anybody remember what the pericardium is? It's the sac around the heart. Like a protective sac around the heart. Say that's my heart, not my avocado. SA node, AV node, bundle branches, and there's this sac around the heart. Pericarditis is inflammation of this sac. Okay, so as this sac becomes inflamed, it becomes swollen. It pushes pressure on the heart. So the sac starts to shrink in on the heart. It now starts to push in on all the vessels of the heart, which kind of makes sense why we have elevation, because we have limited blood flow. And our pressure isn't as high because remember back to Frank Starling's law, the farther my heart contracts or pulls back, the more it's going to squeeze. Well, in this, because there's so much inflammation around the heart, it doesn't have room to expand. So you're not going to have good blood pressure. And then you're running a temperature because your body's trying to fight whatever it is off. If you see widespread elevation like that, that doesn't really make sense and it involves all leads, consider pericarditis. And now, am I saying do not call a STEMI on it? When in doubt, call it out. But remember to be cautious of what it is. And remember that it could be pericarditis. And if the doctor tells you, hey, that's not a STEMI, it's pericarditis, just realize that because you have widespread ST elevation. I know it's something new I threw at you guys. I apologize. Something else that I'm going to throw at you guys. What is, when I say hyperkalemia and hypokalemia, what am I referring to?
Calcium,
Nope.
Potassium.
potassium.
When you hear kalemia, I want you to think potassium. When I have a buildup of potassium, I get what is called a peaked T wave. And see how that peak T wave is really tall and sharp at the end? Taller than my QRS complex? That is generally a very good sign that this patient has potassium issues. This could be a patient with taking too many electrolytes, maybe drinking too many certain types of drinks, maybe taking workout supplements. Who knows? We can also be hypokalemic in the cases of, sweating, dehydration, and we get what is called a U wave. If you look on the left side of the screen here, a U wave is literally your ST segment that looks like a U.
Rudy,
Yes, ma'am.
is there a lead that will be most
No.
evident in? Okay.
No, you should be able to see that in lead 2. So the one that prints out on the bottom, but you generally see it in all your leads, and I'll show you an example of it. That is hyperkalemia. Remember how I taught you guys at one time the difference between a hyperacute T wave, how a hyperacute T wave precipitates a MI, and it's big and rounded. Well, a hyperkalemic T wave is pointy at the end and tall. That's how you differentiate the two. If I look at lead 2, like down there at the bottom, see how tall my T waves are and see how they're pointy? That's hyperkalemia. And this can be an imposter of a STEMI. I don't want you to, don't even pay attention to this. Hyperacute T wave, remember? STEMI, because my J point, I have elevation. Peak T wave, there's my J point. Am I elevated? Is that guy right there elevated or no?
No.
No. That's my difference. This one over here is more rounded at the top. This one here is more pointy at the top. So does anybody know what the treatment is of patients that are hyperkalemic?
Sodium bicarb.
Sodium bicarb and calcium. I don't know anybody that carries calcium, but we all carry bicarb. I was right, calcemia. My bad. Okay, what is hyper and hypocalcemia?
Low and high calcium.
Weird, huh? Okay, hypercalcemia. I will have a shortened ST segment. Hypocalcemia, I have a long QT segment. This prints out on your monitor. It will usually show as QT and then a small c, which means QT interval corrected. If that number starts to get 450 to 500, that is a very long QT interval. Now, when you have a patient that has a long QT interval, a long QT syndrome, what medication should we potentially be worried about giving them?
Zofran.
How did you know that?
We've had conversations with the same people.
We worked at the same place. You got to be careful giving those patients Zofran because you could potentially put them into torsades.
Why is that?
Well, as you elongate that QT even more for some reason, and I couldn't tell, I can't tell you why it puts them into torsades, but it's just some sort of electrolyte issue. And that's a good question that I will have to look up the answer for, and I will bring it back to you. So when you get those long QTs, just be cautious about Zofran. I'm not saying don't give it, just be cautious. And maybe have magnesium ready if things go south. All right. What I am going to do is obviously this slideshow gets uploaded and I put all of them on D2L if you guys have not seen that already. I list them under cardiology. You can watch them. You can skip to points you need to. If you need to review something, by all means, do it. I do have some good news for you. Who has that packet that has 224 rhythms in it?
Yes.
Okay. So what I want you guys to do for, I'd say next class, I'll set aside an hour from 6 to 7 where you guys are going to work on those rhythm strips together. I will put you in breakout groups and you guys will talk through them together. The other good news about it is I no longer am requiring you to do all 224 of them. I am only requiring that you do 100 of them. I will make it worth 100 points. And if you get one wrong, I'm not going to dock the points on it. I want to see you put in the work and try to figure out what it is. Okay. So, and then hopefully at the end of the semester, maybe that'll be our review. We'll go through them together. Next class, plan from 6 to 7. We'll break out into breakout rooms. You guys will work on those packets together for a little bit. We will finish up cardiac emergencies, and then we will be done with cardiology. Sound like a plan, Stan?
Yes.
I thought everybody would be happy about the rhythms. See, I know it's still a lot, but 100 is more realistic than 200. And you can pick which ones you want to do. What I would tell you is make Facebook groups with each other, get in messenger groups with each other, and work through those. It'll help you out in the long run. I promise.
Are we doing P intervals, QR intervals? Are we doing just rhythms and rate?
What is it? What does it say on those underneath them?
Rate, rhythm, P waves, PR, QRS, and interpretation.
So some of those are kind of shady to where you can't read all the boxes. Do the best you can at trying to figure out what it is. I want you to look at, do the best you can on them. The main things I'm going to be looking at is rate and interpretation. But I want you to get in the habit of trying to measure P waves and QRS complexes, measure the duration. But if you can get the rate and the interpretation, I'm good with that, especially if you guys are working through it in groups together. Now, I did want to show you this book real quick. Your classmate Nate sent me a picture of it. Can you guys see that book by chance?
Yes.
That's the book that he got that actually a couple of my students have got so far. And it is probably one of the best books by far. I've been looking through it and it helps you out a ton. So if you can get your hands on that, I probably would.
There's an odd abridged version of that I ordered. I got the wrong one, so you might want to watch and make sure it's the full version.
Okay. All right. What questions can I answer for you guys? Finish up. We're going to work on rhythms next week on your sheets. We're going to finish up cardiology, and then we're going to be done with cardiology in total. What also happens after that is that after we end it, you will have a week to complete your cardiology exam. I will open it up on D2L. You will take it on your own time from next Tuesday till the following Tuesday, and we will move on from there. Any questions?